Good evening, everyone.
Myself, Priya Prabhu.
I'm Dr. Amirtha, and today we'll be doing the grand round presentation moderated by Dr. Lingam Gopal, sir. I'll be starting off with a small case discussion, followed by the discussion by Dr. Priya. So here is a 6-year-old boy who presented with complaints of his parents noticing a whitish discoloration in the right eye. Informant was mother. He was apparently normal 3 months ago, after which he had a history of trauma to the forehead with a table edge, after which the parents noticed the whitish discoloration. Elsewhere, he was diagnosed with...
We stop at this point. Now you got a history of what is the age of the child?
6 years.
So 6-year-old child comes to you with the history that has been given, white color in the eye, noticed by the mother, following query injury. What all would you think of in terms of the mother noticed white eye?
So history.
You think the retina will come into the cornea? So you start from front to back. So you're an ophthalmologist, you have nothing, you're not even examined the patient. But you always have a list in your mind and then tick off each one as you go and examine the patient one by one. That is, you titrate your examination as well as investigation to suit the requirement for coming to a conclusion. So what goes in your mind when the 6-year-old child is brought with white reflex in the pupil?
Corneal opacity.
All right, corneal opacity. What are the chances that a mother notices it at the age of 6 years with history of injury which occurred just few days back? How was the injury?
3 months back,
3 months ago.
It was noticed 3 months.
All right, okay. All right, corneal opacity is one. So if it's a corneal opacity, what is wrong with the history?
That the
What
patient,
should precede a corneal opacity?
the patient should complain of pain and irritation.
So before the mother noticed the corneal opacity, something else you would have noticed, no? At the time of 3 months injury, there would have been a corneal ulcer or something which would have happened, would have been treated for that before it becomes opacity, right? Or injury would have been repaired, okay? So all that is missing, okay? Then the fact that mother brought directly to you with a white reflex in the pupil tells you
So
it cannot be due to that, right? So what else can it be?
So low grade uveitis.
Right, so go from front to back. Cornea, you said. Behind that is anterior chamber. So what will you see in the anterior chamber? Whitish.
Fibrin.
Fibrin, okay. If it is layered, what do you call the fibrin as? In the anterior chamber, if it becomes a white layered area, what do you call that?
Occlusio pupil.
What do you call a white layered hypopyon? All right. Okay. What else? What else is there behind the pupil?
Cataracts.
Congenital cataract or a traumatic cataract. Now, here is history of injury, right? So it can be a traumatic cataract, right? Okay. What happens after that? Behind the cataract?
Behind the persistent hyperplastic primary.
So a retrolental
fibrous
fibrous tissue. So what are the causes of retrolental fibrous tissue?
Retinopathy of prematurity.
All right.
Persistent fetal vasculature.
Okay.
And retinal detachment.
All right. Retinal detachment. I accept it. All right. What kind of retinal detachment usually produces a retrolental retina?
Exudative.
Exudative. All right. So exudative can be due to what lesions cause exudation?
Any posterior uveitis or
Uveitis is one. Inflammatory is one. Okay. Then
any tumors.
tumors. Okay. So the two important causes of exudative retinal detachment which can present right behind the lens, right?
Yes.
All right. Okay. Anything else that can produce white reflex?
So retinopathy of premature
That she told already.
incontinentia pigmentosa.
Okay, retrolental fibrous due to incontinentia pigmentosa. Retrolental fibroplasia, we said, instead of ROP, she said a FEVR, persistent fetal vasculature. Now you are telling about incontinentia pigmentosa. What is the other name for incontinentia pigmentosa? Right, don't worry. Okay, other than that?
Coats disease.
No. Retrolental fibroplasia causes, I'm asking. Coats disease doesn't cause retrolental fibroplasia unless it's been treated and scarred and all that, right? Presenting retrolental fibroplasia, what are the other causes? Let me tell you, retrolental fibroplasia is not an etiological diagnosis. It's a morphological diagnosis. It's caused by many conditions, of which 2 has been mentioned already. You mentioned the third one. Anything else? Trauma can itself cause, right? Toxocara can cause, right? And one rare condition of a tumor which can mimic retrolental fibroplasia is, what are the tumors that come from the ciliary body? Anybody? Any of the fellows? Medulloepitheliomas, okay? So medulloepitheliomas can present sometimes with a retrolental fibrovascular membrane-like picture, but actually it's coming from the ciliary epithelium, the non-pigmented ciliary epithelium, all right? These are some of the causes of retrolental fibroplasia. Behind that, what else can produce white reflex? Behind the retrolental fibroplasia.
Coats disease.
Okay, so retinal detachment, that she has mentioned already, all right? Other than retinal detachment, what can cause white reflex? A tumor in the eye, that's what we are going to discuss now, right? A tumor, what tumor occurs at 6 years of age?
Retinoblastoma.
Retinoblastoma. So first thing always must be on your mind. And you should do everything to exclude that before you do anything else, right? So retinoblastoma, retinoblastoma, retinoblastoma. That must be on top of your mind when a child comes to you with a white reflex, all right? Anything else that can cause white reflex? White reflex does not mean the tissue has to be in the pupillary plane. It can be behind and yet cause a white reflex because it is in the path of the light that is striking the retina. So what else can produce a white reflex not being present in the pupillary area? What is there straight across when you trace the light from outside towards the posterior pole? That can be white in color. Medullated nerve fibers, right? So normal fibers are not, optic nerve fibers are not medullated inside the eye. They're medullated only outside the eye, right? But if there is medullation comes inside the eye, they're called medullated nerve fibers. Large patches can produce white reflex. Similarly, a coloboma, that's also white because it's ectatic sclera, all right? These are some of the things that go in your mind when you examine the patient. Some are so obvious for clinical examination, you don't worry about investigation, but some can be very difficult in diagnosis. Okay, all right, go ahead.
He was treated with topical steroids and anti-glaucoma medications in the right eye. He came to us for a second opinion. With his left eye had no complaints. He had history of episodes of recurrent fever and leg weakness for 3 months, but no history of weight loss or lethargy. There was no history of squinting in either eye, no history of redness, watering, photophobia or proptosis, no history of convulsions and vomiting, no history of contact with pet dogs or cats. His past history had no history of systemic illness or any oral medication intake, no history of intraocular surgeries. There was no history of consanguinity in his family. He is the first child, has a younger brother, but has no similar complaints. No history of blindness or enucleation in the family. No history of malignancies. His birth history included a full-term normal vaginal delivery with a birth weight of 2.8 kg. There was no history of NICU admission or oxygen therapies. His antenatal period was uneventful with no torch infections. There was no delay in motor or cognitive milestones. On ophthalmic examination, he had a normal head posture, no facial asymmetry or dysmorphism. He was orthophoric on Hirschberg testing. His extraocular movements were full and free. Best corrected visual acuity of the right eye was 6/18 using a Snellen's chart and N6 at 30 centimeters, and his left eye was 6/6 with an N6 at 30 centimeters.
There is no refractive error on the other side, is it? Is plano?
No, sir, he was a plano one.
Okay.
This was the slit lamp examination. So rightly pointed out, there was no congestion. There was a hyperpion. There were deposits on the iris. There was also neovascularization of the iris, which was not seen in the picture due to the dilated nature. And the AC reaction showed 3+ cells, with some cells possibly old debris. There was occasional retrolental cells. And there was also a posterior subcapsular cataract. His left eye was quiet and within normal limits. On gonioscopy of the right eye, iris root was closed in all quadrants with posterior synanche. Left eye was open till scleral spur. And the intraocular pressure measured with Goldman applanation tonometry was 20 and 12 respectively. This was the right eye fundus examination.
Okay, somebody else can describe. Because the actual cloud in the vitreous, that's the most important thing, right? Otherwise, this can be even pars planitis. It's the cloud which sets it apart from the pars planitis. That's the most important picture. All right, so to whatever extent you can describe, you can describe. Next person can describe.
Sir, this is the wide field image of right eye fundus. The disc looks, this media is clear, sir. Little bit hazy, but then disc is okay, sir. Vessels are also looking okay. Infratemporally there is elevated lesion in the.
So, I mean, I do apologize that because of the picture being at an acute angle, you can't interpret very easily. But what I would like to show is if you see these whitish fluffy materials, you see this?
Yes, sir.
Those are the most important features that tell us something different story. Okay, you see these pictures, fluffy, and similarly you have got a fluffy material here, and you got white deposits here. And of course, a little bit of RP change here, but that's what we see, right? Okay, go ahead. So what do you see here? You have a hypopion, you have iris deposits, and you have a whitish material in the peripheral part of the retina bordering the ora serrata and pars plana area, right? So with this combination, we need to keep thinking of the alternatives. Okay, go ahead, next one.
On ultrasound, this is the ultrasound of the right eye in the orbit mode. Lens echoes were seen. In the vitreous cavity shows moderate dot-like hyperreflective echoes. There was a clump echo in the inferotemporal far periphery here, which mostly looked like it arised from the retina. The choroid and the optic nerve head shadow was normal.
What are we looking for an ultrasound?
The status of the lens, the retina,
Ultrasound.
the lens echo.
Lens is clear here, absolutely, except for the PSC cataract.
Whether the retina is attached, the choroid status,
Okay.
the calcification in the vitreous
Yeah, that's the
echoes.
most important thing, okay? We're looking for any calcification, and of course a mass lesion first, okay? Now, if this is pars planitis, let us assume, because that's one of the most important differential diagnosis, right? If it's pars planitis, what would you expect on ultrasound? At a stage when he has 612 vision and 6 vision, first time coming, what is it that you would likely expect? I'm not saying that anything is yes or no answer, but what is it you would expect in a pars planitis when you examine the fundus in the periphery? Any uvea fellow is here?
Snow banking
Medical
and
retina uvea?
snowballs.
Okay, why don't you answer the question?
Vitritis, the vitreous echoes will be more.
Vitreous echoes. Now, let
Like
me ask
your
you a straightforward
vitreous
question. I'm putting a differential diagnosis here of a pars planitis versus a retinoblastoma, all right? What do you think are the features for and against? Tell me. Let us say first for pars planitis. What are the features for pars planitis?
There
Quick,
are
quick.
few vitreous echoes.
First, start with the age. 6 years is okay?
6 years.
It is okay. Why not? Children of 3 years also can develop pars planitis. Okay? All right, then. Unilateral, is it okay? Or has it to be bilateral? Unilateral is
Usually
okay.
bilateral, but asymmetric can
It
be.
can be unilateral. Start with unilateral, right? Presenting with not congested eye, with no CCC, is it okay or not okay?
For pars planitis, yeah.
Usually it is quiet, right? Okay. Hypopion and antechamber cells are okay.
No.
Hypopion is relatively rare, right? Certainly with acute uveitis you get, not with a pars planitis. Okay? All right, then. PSC cataract is okay or not okay?
Yeah. That
Is
can
okay, all right? What about the lesion there we are seeing?
It's
What does pars planitis present with?
exudates in the
It
vitreous
presents with
tract.
pre-retinal clumps of exudates, right?
Yeah.
Now, these very well can be pars planatis exudates. Nothing stops them from being that, right? So everything here is supposedly not against a pars planatis diagnosis. If in this case we don't do OCT, suppose you do OCT, and if the macula is normal versus a macula which is edematous, how does it tilt your diagnosis?
Edematous macula will be more towards inflammation.
Yeah, so it's actually a very, very important point. If you have cystoid macular edema, along with these features, your diagnosis tilts towards inflammation, because retinoblastoma doesn't cause macular edema at all to start with, right? Unless it's a treated eye or something else happened, it never causes, except a necrotic retinoblastoma, you cannot get this thing. Now this patient has got N6 vision. Okay, that's a very good point to tell us that probably the fovea is quite okay. Nothing stops a CME not to have N6 vision, but likely. And there is anisometropia, maybe that explains the slightly reduced vision in the right eye. Okay, but we should have done OCT, that would have been ideal, all right? Okay, what are the features here that you think could be in favor of a retinoblastoma? Or a tumor basically. Age is not against.
Hypopia.
Is it against or for? For, okay. So which kind of, what is the age group in which you get this kind of presentation? What is the normal age group of a presentation of a retinoblastoma? I will give you a description. Unilateral mass lesion in the fundus retinoblastoma. What is the age of presentation? Usually. Nothing specific about it. Or in other words, which is the kind of retinoblastoma which presents earliest? Heritable bilateral retinoblastomas present earliest. Even at the age of, at birth also it can be there, maybe first 2 years of life it can be there. While unilateral typical retinoblastomas present a little later, maybe 3 years, 4 years of age. So what is the kind of retinoblastoma we are talking about? Yeah, something which is more muscular. It's not exactly a diffuse infiltrative, because we have not proved it's diffuse infiltrative. But if it's a diffuse infiltrative variety, it occurs at a much later age, 6, 7 years, even beyond. Also it can occur, okay? These are 3 stages it can present. So age is not a bar in this case for diagnosis. Unilaterality, is it a bar against diagnosis? Not really, all right? What about the circumciliary congestion? Okay, it's more in favor, not against, all right? Hypopion?
More in favor.
Typically, what is the kind of hypopion you see in retinoblastoma? What is this kind of pseudohypopion you see?
A mobile.
It's a cold pseudohypopion, sir, where there is no pain, no signs of inflammation.
No, not only the characteristic of these
It's
materials.
a mobile. It's a mobile hypopion made up of only the malignant cells.
It's usually not a mobile hypopion. Usually, unless there is a reactionary inflammation, the retinoblastoma cells themselves, they stick to the tissue. So they don't move, unlike a WBC. WBC are layered and they are in a fluid space. So they form a perfectly horizontal line. So a real retinoblastoma cells in the antechamber, they don't form a horizontal line. They form like a clumps, stick to the, no doubt inferiorly they can be more, but they're there all over the place. And they stick to the iris and then they grow in each place where they are stuck. So typical hypopion is not what you see in retinoblastoma, all right? Okay.
Can I make one comment,
Yeah.
please? I just wanted to ask you, you said you saw the ultrasound and decided that it originated from the retina. What finding on that ultrasound tells you that it originated from the retina?
Ma'am, I was thinking in this region, the mass looks like it's attached to the retina.
Okay. Basically, what has happened is you see that the retinochoroidal layer, okay? As you follow the retinochoroidal layer, you suddenly see the contour is changing a little bit. And then you have those low reflective echoes which are stuck to the surface. It's difficult to separate the retinal layers in an attached retina. So whether it originated from the retina or it's stuck to the surface, if you're looking at far periphery, there is only one way to find it out, and that is
UBM.
UBM. Okay, the UBM only will be able to give you that magnification and that high resolution to tell you that yes, this is not just stuck on the surface, it originates from the retina.
Yes, ma'am.
Okay. So if we again go back to the pars planitis versus retinoblastoma discussion here, by the time a pars planitis leads to a very high reflective lesion like this, it's usually quite late in the development of the disease. When it is just actively exudative lesion, you get clumps usually along the blood vessels, and then a few clumps like a candle wax dip, not exactly candle wax dipping, but along the pars plana area. But it need not be elevated to such a high level at a stage when the patient has just presented to you. It's only after some amount of time has elapsed and it's become scarred or fibrotic partly, then you start having this kind of a high echogenic lesions. Okay, otherwise you'll be clumps of exudates which don't produce that kind of a high reflective and irregular jagged kind of edge you won't get. Okay, so that's one important reason why we were thinking about other possibilities. Now we go back to the fundus picture. Now here if you see very carefully, you see this particular fluffy material in the vitreous cavity here.
Yes.
Do you see that?
Yes.
So that is the most important giveaway. I don't think you would expect this kind of an exudation in the vitreous with an otherwise absolutely normal retina and optic disc and macula in a case of a pars planitis. You get mostly some exudation here, some intraretinal or pre-retinal exudation here, but not this kind of a fluffy material floating around. That is the most important giveaway. Okay? All right. Now go ahead. Presentation.
We proceeded with the UBM. This is one frame which showed a ciliary body thickening from 5 to 7 o'clock. There was a solid, highly reflective lesion noted behind the ciliary body, measuring 1.75 mm into 0.82 mm. This lesion appears to have no invasion of angle, iris, or the sclera.
So while they are going through with that, let us come to a complete different clinical scenario where there is no view of the fundus. Let us see. Now in this case, one more point we want to discuss, the PSC cataract. Is it in favor of inflammation or retinoblastoma? Yeah, so it's actually pointing against retinoblastoma, right? Because retinoblastoma doesn't present with cataract formation, except that in this case also is compounded by history of injury. Although why should injury produce a PSC cataract? I don't know. Okay? So that's a little confusing picture, right? But somebody who comes with no view of the fundus and you're relying entirely on imaging. So what are the ultrasonographic features that tell you you may be dealing with a tumor in the eye?
In USGB scan for retinoblastoma, like we need to detect a possible retinochoroidal mass lesion.
Retinochoroidal? Is it resulting from the choroid or retina? Which ways does the retina grow? What are the two major directions in which it grows, the retinoblastoma? Endophytic and exophytic, right? So, and exophytic doesn't mean it will burrow into the choroid.
Yes,
So, how does it present as? Retinal detachment with a subretinal mass, not into the choroid.
Yes,
So, it's not a chorioretinal mass.
Chorioretinal.
It's a retinal mass, all right?
Yes.
Okay, then.
With calcifications.
So calcification is the hallmark of retinoblastoma on ultrasound. Okay, so you look for it very, very carefully. Okay, all right. So you see mass lesion, one or more.
Yeah.
If you see one, doesn't mean you stop with that. You scan the entire fundus. One or more retinoblastoma lesions, which could be underneath the retina causing secondary RD. If it's pre-retinal, it can still have secondary RD, but it need not have. You can have just a tumor sticking to the eye wall with no retinal detachment. Okay, what else can it have other than retinal detachment, which you already mentioned? Mass lesion you have mentioned.
Vitreous seeding.
Yes, vitreous seeds can be there, which may be large enough to be picked up on ultrasound. All right. Now suppose let us assume endophytic type, exophytic type. We talked about diffuse infiltrative. How would that look like on ultrasound? Because that can be easily confused. No view of the fundus. And what you are looking at is something which can be confused with other conditions. So how do you diagnose an ultrasound a diffuse infiltrative or suspect?
we can see retinal thickening in areas.
It will be usually a diffuse retinal thickening.
Yes.
Because it's diffuse infiltrated, by the time it produces no view of the fundus, almost entire retina is affected. Okay? So it's not like a small patch anymore. So by that time, the entire retina will be thickened and will be like lumpy thickening. Okay? So which is next, of course, we'll discuss about the differential diagnosis. Go ahead.
So we
These
got
are the
fine.
other optosims.
Yeah. Now here you can see that fluffy material. This is what I meant. Okay? Okay. So remember that if you have vitritis-like picture with macula totally normal, disc totally normal, no disc hyperemia, nothing whatsoever, with a very good vision maintained, then you are shifting away from the inflammatory pathology. That's the most important thing. Okay, here we are clutching at small clues. This is not a gross diagnostic feature that you are seeing. So when you're looking at small clues, you should dissect to the finest level. Only then you come to the right conclusions. Okay. So the color of the lesion unfortunately cannot be used to differentiate, because an early pars planatis can also look like this, yellowish white in color. But a retinoblastoma is more whitish than an inflammatory exudate. Okay. But these are all plus minus features. Okay. All right, go ahead.
Should I go to the next slide? This was the UBM finding. There was a small, highly reflective lesion noted behind the ciliary body, and that appeared to have no invasion to the angle iris or the sclera. The lesion is right
extending
here.
even anterior to the point where we saw in the fundus picture. That lesion is extending forwards. Okay.
We proceeded with the MRI orbit and brain, which showed normal study.
What are you looking for an MRI?
We are seeing if the lesion is extending mainly into the optic nerve.
Do you expect it in this case?
No, the lesion is quite
It is so
small.
anterior located,
Yeah.
right?
Yes, sir.
But other than that, why did we do MRI?
To check for calcification.
Calcification, is it picked up on MRI?
No, mostly on ultrasound.
Well,
Other
yes, there is no
correlated.
trilaterality because otherwise is probably normal, because we have not done GE examination as that, mind you. So it is very well possible otherwise may be harboring a small tumor in the periphery which you have not picked up. So as a routine, any of these tumors must be imaged by more than one imaging study, but it gives you definitely more information. In this case, probably it's a little overkill at this stage, but yes, it is definitely required. Okay, all right.
A glaucoma opinion was taken, and he was diagnosed with right eye secondary angle closure glaucoma with the neovascularization.
Okay,
of
any
the
glaucoma
iris.
fellows are here? Okay, what are the causes of angle closure? Why does angle closure glaucoma occur in this case?
So pupillary block occurs in retinoblastoma.
Why should pupillary block occur in retinoblastoma?
Iris neovascularization and peripheral anterior synechiae also
She
forms.
did tell you classically NVI present already, right?
Yeah.
So that's what you should be thinking about, not pupillary block, right? Why should pupillary block occur in retinoblastoma, which is behind the lens? Why should it cause pupillary block glaucoma, right? So here it is mainly NVI which is causing the angle closure, right? Okay, go ahead.
He was advised to continue the anti-glaucoma medications. Family screening was also done. Parents and the younger siblings were screened, and the fundus showed no abnormality.
Do you think the presence of NVI in the iris gives you also a clue towards which way we are trying to move?
Yes, sir.
Why?
It points towards infiltrative pathology. Usually in tumors only we have neovascularization.
Can pars planatis have NVI or not?
It can present, sir. But
Can
on
have, but
chronic
it
stages.
has to be very late
Chronic,
stage,
yes, sir.
not at a stage that we are seeing it produces neovascularization of the iris, okay?
Yes,
So that is definitely a point against pars planatis.
Yes, sir.
Go ahead.
The differential diagnosis we concluded were a unilateral retinoblastoma, group E, which is likely infiltrative with NVI and NV neovascular glaucoma, leukemia or pars planitis. So why leukemia? Hypopyon can also present with leukemia. This is an in-house article that was published of a 4-year-old female child with a right eye vision of 6/6 and a left eye vision of 6/7.5. On examination, left eye revealed a blood-tinged pseudohypopyon with hazy lens. An AC tap was done, which showed.
Let me stop at this point. How do you know it is pseudohypopian at this stage? Pseudohypopian is an inference, not a finding, right? So at this stage, you say it's hypopian.
Okay.
You knew it later only that it is leukemic infiltrate and not WBC, right?
Yes.
Even those are still WBC, but abnormal WBC, not normal WBC. So it's still hypopian. Okay.
The fundus view was hazy, but appeared normal. So when we did an AC tap, blast cells were seen, and she was a case of a relapse of an acute lymphoblastic.
So it's a known case of ALL.
Yes, sir. And she was started on chemotherapy subsequently, and the hypopion resolved after 2 weeks of chemotherapy.
I thought you had a fundus picture also in this case, no?
There was no fundus picture for the.
All right. You want to say anything about that? Leukemia?
I think in this case, the important point was that the child was a known case of ALL, wherein an AC tap was done at this stage itself. Another thing is, if you're suspecting leukemia, you can do and it's not a known case of ALL like in this case, you may want to do a peripheral smear along with the other blood investigations that you will routinely advise for the child, because that child should be posted for an EUA. Suppose there was no history of ALL, even this child should have a differential diagnosis of an RB at this stage.
Why? I mean, can we diagnose this without the IC tap? It's a known case of ALL anyway, right?
Yes, sir.
Why do you think the AC tap was required?
To confirm if it's not due to any other infectious.
Because I said clearly there are relapse of ALL. That means at that time he is in remission, right?
Yes.
You don't get a hypopian due to leukemia during remission. Okay? And during remission, patient is off all chemotherapy. So you can't even think of endogenous endophthalmitis or something because of immune suppression, right? So that's why you're in a diagnostic dilemma. That's why you did AC tap. Okay? You could also have done a peripheral smear, I'm sure. It would have been done in this case, although we don't have the details. Okay, go ahead.
Yeah, one question. You have a 6 by 7.5 vision in this patient. You say fundus is hazy due to a lens haze, but it appeared normal. What are the fundus findings you would expect in a patient with leukemia?
We can expect signs of leukemic retinopathy such as neovascularization. We can have
Neovascular?
No?
Leukemic retinopathy, what are the fundus findings?
We can have direct leukemic infiltrates. We can have vitreous hemorrhage.
Vitreous hemorrhage?
Rod spots.
Yes, tell me.
Rod spots.
Shamika. Because to say some very often the ophthalmologist makes a diagnosis of leukemia. No? So what do you see? You can look at the other eye also to see. What do you see for leukemia?
Somebody's asking.
Leopard spots on the retina.
Leopard spots.
Ma'am, rod spots.
This is a 4-year-old female child, so let's put it in this context.
Ma'am, in leukemia, most of the time the patients will be anemic, so pale fundus and rod spots will be there.
Talk about leukemia. Leukemia per se can cause a problem, or the associated features can cause a problem. Like you rightly pointed out, anemia. So anemia, thrombocytopenia, all those things can also cause a problem. And they also have another condition where hyperviscosity. So you have to classify it that way. That is leukemia, you have it as chronic phases, progressive phases, blast crisis. So depending upon whatever phase you have, your features would also change. So it could vary from mild, moderate, severe. Very easy to put it that way. There is a proposed classification where we say milder forms, all these rod spots will all get categorized into that. The hemorrhages will get categorized into that. A little more moderate form, your uveitis, anterior uveitis, hypopion will all come into the moderate category. When you go in and you have the occlusion also coming in that, the severe category will be where you will have the proliferative features. So you could easily classify it as the different, depending upon the clinical features, what phase of leukemia you have, you could have it. So either anemic manifestations can be there, leukemia per se. So these things are seen at two phases. Whenever you have these kind of leukemic things, either a diagnosis, a patient would present with not being diagnosed as leukemia, will come to the ophthalmologist first, or in the relapse stages. That is when you have interval changes. When you have, will be related to intercurrent infections or something like that. That will be because of the coexisting abnormalities. So if you kind of put it that way, it's easier to club your symptoms or the signs what you get to see in the retina. So anterior segment will have anterior uveitis, you will have hypopyon. Sometimes you tend to have iris infiltrates like what you saw here. The same feature can be there in leukemia as well.
The plan for our patient was to do routine labs with a complete hemogram, uveitis workup, and a peripheral blood smear, and to continue the anti-glaucoma medications. Then proceed with examination under anesthesia with a bone marrow biopsy and cerebrospinal fluid assay, and to do a trial of triple drug intraarterial chemotherapy of 3 cycles with intravitreal or intracameral topotecan.
He didn't follow up with our treatment, so we'll forget about it for the time being. Let's go ahead with other discussion.
Yes.
So the common signs of RB, which we all are aware, are leukocoria, which is the common presentation seen in 50% of patients. The next common sign is presentation is squint, which is seen in 20% of the cases. They can also present with proptosis or sterile orbital cellulitis, or they can present as a fungating mass, or they can have neovascular glaucoma.
Can you go back for a second? I think it's also important to mention from which part of the globe you're quoting these percentages. If you're seeing up to developed countries versus a developing country, in a developed country, fungating tumor or cellulitis would be very, very rare. Cellulitis can still occur because of necrotic tumor, but a proptosis and a fungating tumor is almost never seen in the developed countries. They will always, mostly will see as leukocoria or as strabismus. But if you see things like even in parts of India, in 1970s, in fact, if you see the article in Indian Journal of Ophthalmology in 1975 or 76 of case series of retinoblastoma, the most common presenting feature was proptosis, not leukocoria. The most common presentation was proptosis. From there, we have progressed much better now. So for us now, leukocoria is the most common presentation. Okay, yes, right. So in Africa, if you go to some parts of Africa, you will still get proptosis as the most common presentation. Okay, go ahead.
The less common camouflaging signs include white eye hypopyon, as in our case. It can present as phthisis bulbi, as buphtalmos, or it can also present with hyphema or vitreous hemorrhage.
Okay, can you go back for a second? Why should it become phthical eye? It's after a tumor which is growing, multiplying, occupying more and more space. Why should it become phthical? Anybody else?
Sir, because of ciliary body shutdown involvement or shutdown.
Okay, if ciliary body involvement, that also keeps growing. Why should it become phthical?
Blood supply because of growth.
That's a little far-fetched, okay? Any other explanation you have in your mind? What can happen if the tumor outgrows its circulation? It grows so fast that it outgrows its circulation. What can happen to it?
Necrosis.
It can undergo necrosis, right?
Yes.
That can happen both in melanoma and also in retinoblastoma. So if it undergoes necrosis, it produces so much reaction which can shut down the ciliary body because of the inflammatory reaction and can land into phthisis. Okay? So do you think phthical eye is now free of tumor?
No, sir.
Huh?
That in every phthical eye also we have
It's
to
necrosis which has destroyed the tumor, destroyed the eyeball. Do you think it's still harboring active tumor?
Yes, sir. It can still harbor.
It can still harbor active tumor, yes. Okay. Go ahead.
We have reported a case of phthisis bulbi in retinoblastoma, which is very rare. The eyeball was shrunk and there was a calcification, extensive calcification and necrosis with inflammation, and a lot of fibrosis was there.
Okay, go ahead. Or vitreous hemorrhage.
Bleeding from neovascularization, sir.
Okay, all right. Buphtalmos, secondary glaucoma.
Yes, sir.
Okay. So secondary glaucoma occurring at the young age produces rapid enlargement of the globe versus occurring a little beyond 6, 7 years of 8 years of age. All right, go ahead.
So the differentials for a hypopyon can be broadly classified into inflammatory, infective, and infiltrative. So inflammatory causes of hypopyon include Behçet's disease, HLA-B27 uveitis, psoriasis, Rita syndrome, inflammatory bowel disease in Crohn's, pars planitis, and juvenile idiopathic arthritis are relatively rare causes. It can also be seen in as drug-induced. The causes include rifabutin, which is an antibiotic which is used for Mycobacterium tuberculosis treatment. Anticonvulsant topiramate, it can be a reaction to drugs like alendronate, bisphosphonate, which is used for osteoporosis treatment, and rarely for antiviral drugs like cidofovir. In HLA-B27 uveitis, almost 82% of the cases they present with hypopyon. And in Behçet's disease, they have a characteristic cold hypopyon, which is seen in 7% of cases, and there is no associated inflammation.
You get fibrin also along with it.
Yes, sir.
With the hypopyon. So that is very characteristic.
Okay.
The infectious causes include keratitis, endophthalmitis, herpetic uveitis, and in rare causes where we have published a case of tuberculosis which presented with a pigmented hypopyon, and also in parasital infections.
If you have a
like
black hypopyon, what is the cause? Listeria.
Listeria. And the third category is due to infiltrative causes, where it is called as a pseudohypopyon or a cold hypopyon, where it is seen in extremes of age, where the eye is characteristically white without any signs of inflammation and patient doesn't have any pain. And the contents of the hypopyon, it is made up of the malignant cells. The causes include, it is seen in almost 2% cases of retinoblastoma, mainly the diffuse infiltrating type, and it is classified into the group E. Retinoblastoma. The other causes include leukemia. It is seen in acute as well as in chronic myeloid leukemia and acute lymphoblastic leukemia. And in metastasis, also it can present with a pseudohypopyon, where in literature we are having a case of cervical carcinoma which had presented with a blood-tinged hypopyon. And characteristically, mantle cell lymphoma presents with a candy cane hypopyon, where there is alternating bands of hypopyon of hyphema along with the white color of the hypopyon. And it is also seen in herpetic uveitis. So the differentials which we had in mind were retinoblastoma, leukemia, and pars planitis. They can be age was. So the age for retinoblastoma, it is between birth to 5 years, and as I had told, heritable cases present much earlier, and non-heritable cases present much later. Leukemia, it is characteristically seen between 1 to 4 years of age. Pars planitis can present at any age, though it's more common in children and young adults. Laterality, both retinoblastoma and leukemia can be unilateral or it can be bilateral, and pars planitis is mostly bilateral, but it is asymmetric. The hypopyon nature, it is made up of the infiltrative RB cells and or the leukemic cells, whereas in pars planitis it is made up of the inflammatory cells. Signs of inflammation are characteristically absent in retinoblastoma and leukemia, whereas it is present in pars planitis. Fundus examination in retinoblastoma may reveal a creamy yellow-white lesion. There may also be subretinal or vitreous seeds and associated retinal detachment. In leukemia, we can see the features of leukemic retinopathy. As ma'am had told, we can see in the features which are caused due to the leukemia per se or due to associated anemia or thrombocytopenia. And in pars planitis, we can have the inferior snow banking and snowballs with vitritis. Investigations, retinoblastoma is easily detected on ultrasound, which shows a characteristic calcification with
Okay, now in this case, we did ultrasound and MRI.
Yes, sir.
Could a CT scan be done
No, sir.
instead of ultrasound? Huh?
No, sir.
Why you cannot do it?
Sir, because sometimes radiation can also, radiation can increase the, growth of the tumor, sir.
Radiation will increase the growth of tumor. Why is CT scan relatively contraindicated? In this case, I would say it's not contraindicated at all, because at the age of 6 years, the risk is really not much. It's only up to the age of 1 year that they have seen using a CT or any radiation increase the risk of secondary tumors in heritable tumors. Heritable retinoblastoma, where all cells already have one hit, then they are at risk of developing a secondary tumor in the area of the radiation if it is done below 1 year of age. Beyond 1 year of age, actually the risk is not very high. So if there's a strong doubt and you want to really look for calcification, CT scan can definitely be done in this case, okay? All right.
Why CT is not done is optic nerve will not be able to, get a better picture. It may not all the time show the thickening of the optic nerve. That's the only reason why. Otherwise, we could do, and in fact, CT can be done faster than MRI also. You don't need a GA as well. They can quickly do it off.
Here the MRI was done mainly to see if we can locate a lesion within the eye, because on examination in the OPD as well as on ultrasound, although we could see that there were a lot of vitreous seeds, a clear mass was not characteristically visible. So just to look for an intraocular mass for the diagnosis, here the MRI was done at this stage.
And so the minimum size for a mass lesion to be picked up in MRI is at least 3 millimeter. Our case was 1.8, which could expose.
Anterior, see where it is not visible to you, it's not that posterior to the retina, MRI picks up better than your ophthalmoscopy, no. Yes, anteriorly near the ciliary body area, pars plana epithelium area, and pars plana epithelium also can be a site for retinoblastoma. Yes. So that can be may not be easily visible, which is the reason why we ask for MRI. Anyway, we routinely ask for MRI, so we ordered for MRI, right?
For leukemia, on blood and bone marrow aspirate, and on AC tap, we can show the leukemic cells. And in pars planitis, we can do the uveitis blood workup. And treatment of the retinoblastoma depends on the grouping. And leukemia, we can have bone marrow transplantation or chemotherapy. And pars planitis, they respond well to steroids. So next differential.
I think we went through already, so we don't have to repeat it.
Yes, sir.
Just go forwards.
So the
whatever we have discussed, just skip it. We don't want to waste time on that.
Yes, sir. So for leukocoria, the histories which are important include a history of ocular trauma, which is important for retinal detachment, cataract or vitreous hemorrhage, history of prematurity and NICU admissions and oxygen therapy for ROP, skin lesions which are characteristically seen in incontinentia pigmenti. It presents in 4 stages. The first stage is the vesicular stage, then the verruca stage, then they have the hyperpigmented stage and followed by the hypopigmented stage. And skin lesions are also astrocytic hematomas are a close differential for early retinoblastomas, and they are associated with tuberous sclerosis as well as neurofibromatosis. In tuberous sclerosis, we have the characteristic ash leaf macules, shagreen patches, the facial angiofibromas, and subungual tumors which are present. And in neurofibromatosis, we have the characteristic cafe au lait spots, and we have the skin neurofibromas. So past history in infectious cases, history of arthritis and juvenile idiopathic arthritis, which is a close mimicker of RB. Prenatal history of torch infections is important. Exposure to pets, dogs in case of toxocariasis, and we should look for a source of septic focus in case of endogenous endophthalmitis. Family history is important for retinoblastoma, but it is present in only 10% of the patients. It is autosomal dominant with incomplete penetrance, and it is the positive RB1 mutation has also been included as a part of the RB-TNM staging. FEVR, it is autosomal dominant inheritance. RC coloboma, which is also presentation as a leukocoria. It has a mutation in the PAX6 gene on chromosome 11. Incontinentia pigmenti is X-linked dominant. Laterality, mostly non-heritable RBs, they are unilateral, and heritable RBs are bilateral, which is seen in 40% of cases. Coats disease mostly is unilateral. PHPV is unilateral. Toxocariasis is also unilateral. FEVR, it is asymmetric, but it is bilateral. ROP is also bilateral. Astrocytic hematomas and endogenous endophthalmitis also is bilateral. Coats disease can rarely be bilateral in cases in patients with facioscapulohumeral dystrophy, and PHPV can also be rarely bilateral. So we also look for strabismus, which is a sign in retinoblastoma. Visual acuity is difficult to elicit.
So which types of retinoblastoma present with strabismus? Anything specific about it? Macular. It's macular, means basically a posterior pole lesion which is affecting the vision. Only then the eye can squint. So peripheral lesions need not present with strabismus. Okay, all right.
Mainly we have to look for whether the child is able to follow the light, whether it is steady and maintained, the refraction of the child, especially important in ROP, and the visual acuity is in Pre-verbal children, we can also use the telovisual acuity chart. The intraocular pressure, it is elevated in retinoblastoma or Coats disease due to neovascularization. Conditions like JIA, it might be elevated due to trabeculitis. The pupil having an RAPD is a poor prognostic sign. The color of the pupillary reflex, the characteristic white leukocoria, it is seen in retinoblastoma, whereas yellow color of the pupil called as xanthochoria, it is seen in Coats disease. And in
I think this is a very, very important point I would like to stress, that Coats disease is an important differential diagnosis for retinoblastoma, presenting as a leukocoria. If you go back into the history, like Lawrence Zimmerman's articles, where the most common misdiagnosis of a enucleated globe of suspected retinoblastoma is Coats disease. Because in that era where they used to be aggressive, the minute they see retinoblastoma, they used to enucleate the eye. And the incidence was very, very high of Coats disease being falsely enucleated as retinoblastoma. So the color of what you see in retinoblastoma versus Coats disease is rather typical. In one eye you get more towards the white, the other one is more towards yellowish. Okay? All right, go ahead. Why is it so?
In Coats disease, we have that exudative component with the cholesterol crystals which give the characteristic yellow color.
And the lipid, basically, Coats disease is a lot of lipid under the retina, within the retina, in front of the retina. Everywhere there is lipid.
Yes, sir.
And it's the lipid which gives you that yellowish color. Okay? Not so much cholesterol crystals. Okay, go ahead.
Anterior segment examination, the associated features in case of PHPV are microophthalmos, microcornea, shallow anterior chamber, persistent tunicovasculosa lentis, cataract, fine vessels which are causing over the iris to the anterior lens surface, and retrolental fibrovascular membrane. In an anterior chamber RB, as in our case, we can have fluffy white seeds which are present on the iris, or it can present with a pseudohypopyon. There are two types of anterior chamber RB. One is the depository and the other one is the infiltrative type. And there can also be associated neovascularization, or it can have hyphema. Coats disease, we have rarely the anterior chamber cholesterolosis, where we see the free floating crystals which are seen in the anterior chamber. In iris coloboma, which is associated with an RC coloboma, and AC inflammation is seen in inflammatory causes of uveitis and also in infectious causes of endogenous endophthalmitis. And NVI and glaucoma, as we discussed, it can be seen in RB and Coats disease, or even in any wrong-standing retinal detachment. Fundus examination, the vitreous in Coats disease, the vitreous is clear. Vitreous seeds may be present in retinoblastoma, depending on the staging. Vitritis is present in toxocariasis. Endophthalmitis.
Now, 1 second. If you see this cloud here, not this big one, this is exactly how the cloud is in the case of what we are trying to study. Okay? All right.
There are three types of vitreous seeding. One is the dust type, the next is the cloud type, and the third is the spear type. And in pars planitis, we have the characteristic stone banking, and persistent hyaloid is noted in PHPV. So optic disc, what are the anomalies which present as leukocoria? Morning glory syndrome can present with leukocoria. RC coloboma also can present with leukocoria. In PHPV, we can have the Burgmeister papillae, and we have the fold arising from the disc going to the periphery, or a characteristic fold which goes from the disc all the way up to the lens anteriorly, and there may also be TRD associated with it. So the retinal vessels, mainly to differentiate between RB and Coats disease. In RB, there are dilated tortuous vessels which dip into the tumor. This is an FFA image which shows the hyperfluorescent tumor where there are tortuous vessels following for each tumor. Whereas in Coats disease, we see that the dilatation is irregular. We have the saccular enlargements in the periphery. We are having associated telangiectasias, and the vessels course along the course of the retinal detachment. In FEVR, we have the peripheral dragging from the FVP, and there may also be a tractional component associated with it, also seen in ROP.
Yeah, just one point I would like to say again. This point is probably the most important thing. When you see elevated retina behind the lens, you look for these telangiectatic vessels. And when you see them, you know 100% that it's indeed a Coats disease and not retinoblastoma. When we said about yellowish versus whitish tinge, I can tell you my own experience of a patient whom I saw in the clinic, in a very busy clinic. Somebody brought me a young child with yellow reflex, small child, not very cooperative. So one quick look, and I said it could be Coats disease, but we'll investigate. This is what I told them. And next day the patient came with pain, with high pressure. And that time when I examined, it was looking like RB, not like Coats at all. So a quick examination, you can always make a mistake. So don't go by the color and say, okay, this is yellowish, it is Coats disease, and whitish is retinoblastoma. Well, you can make a mistake even after years of experience, you can make a mistake. So that case actually happened to be retinoblastoma of the diffuse infiltrative variety. And the ultrasound showed lots of echoes in the subretinal space. And I was willing to start an intravitreal, intraarterial chemotherapy for that patient because the parents wanted the eye to be preserved. Meanwhile, these pictures were sent by the oncologist to USA, to one Dr. Watson or somebody, I don't know who he is. So he is supposed to be international retinoblastoma expert from some clinic there, and he conducts regular classes across the globe. So one look at the picture, he said, this is Coats, that guy is making a mistake, he said. So that oncologist came running to me and said, you're going to give chemo? No, this is the opinion from USA. Then I only asked her, has he examined the patient? She said, no. Okay, so I have examined the patient. I'm fairly confident I'm dealing with retinoblastoma, not Coats disease. So I spoke to the parents and told them that this is the contradictory opinion from US, but this is my opinion. Are you willing to go through the intraarterial? Parents said, go through. To cut the story short, after 2 cycles of chemo, the eye was insalvageable. At least I thought there was no regression at all. When we nucleated the eye, there was already choroidal infiltration for retinoblastoma. So it can be very misleading. An experienced person can make a mistake. So don't underestimate the difficulty in diagnosis sometimes. Okay. So this could be a very, very important feature you're looking for. All right. Okay.
So retinoblastoma types, endophytic, exophytic and diffuse infiltrative type. Endophytic mostly presents with vitreous seeds, exophytic has the subretinal seeds, and diffuse infiltrative is what presents with the mostly as the hypopyon.
Again, a given tumor can have both components, endophytic and exophytic. Nothing segregates them. It's just the way they're growing. Okay? All right.
So the next step. The common mimicker of an early retinoblastoma is an astrocytic hamartoma, where there are flat or elevated lesions, and these lesions don't grow much over time. And
was this case our case?
Yes, sir. This is our case. Sir.
It's not having typical features of astrocytic hamartoma. It's more like a combined hamartoma, if you ask me. Is there an angiogram present for this case available? No. Okay, anyway, go ahead. Because you can see the anomalous kind of disc, you can see the anomalous vessels here, but I don't see RP hyperplasia, I agree, but gliosis is there. This is not very typically an astrocytic hamartoma presents.
No.
This child is, if I remember correctly, this is a child who is receiving mTOR inhibitors. This is post-treated. This child had exudative RD, regressed, and with mTOR we are working on this child.
Okay.
It had total RD.
Okay, go ahead.
And astrocytic hamatomas can also present with calcification, which can be picked up on ultrasound. There are two types. One is a calcified variety and the other is a non-calcified variety. Coats disease.
Just to halt at this stage, astrocytic hamartoma can clinically mimic 100% like a retinoblastoma. It is not possible sometimes to diagnose it apart from retinoblastoma. The only way you can be sure is, of course, the other telltale history and the possible growth. Again, to tell you a story of a patient who was seen by my boss, Dr. Badrinath, and suspected to be astrocytoma, sent to a skin specialist. He said there are some features of tuberous sclerosis, okay, of Bourneville disease, and so he said, no, now he is quite safe, it's probably astrocytic hamartoma. But on follow-up, it started growing, and ultimately that I had to be nucleated, it was retinoblastoma. Okay, so the flip side is that a patient with some features of tuberous sclerosis need not necessarily have only astrocytoma, he can have retinoblastoma also. It's just coincidental probably. So it can be misleading sometimes. Okay.
In Coats disease, we have the characteristic saccular dilatation and telangiectasias. And on ultras, they can also have the subretinal gliotic nodules and macular exudates, which can be seen in Coats disease, which can be mistaken for a retinoblastoma.
No, I think this can never be mistaken for retinoblastoma. This is a dense scar under the macula. At this stage, nobody will mistake this with retinoblastoma.
Yes, sir.
If you've seen one scar, you have seen hundreds, okay? So, I don't think at this stage anybody can make a confusion with retinoblastoma. Go ahead. It's with the secondary RD behind the lens. Yes, there you can make a mistake. Not at this stage. Right?
Ocular toxocariasis, it has vitritis and there is retinal or subretinal granulomas which mimic exophytic retinoblastoma, and it can also present with hypopyon and retinal detachment. Endogenous endophthalmitis, there might be associated vitritis with a subretinal abscess which may rarely mimic retinoblastoma, but we have the characteristic signs which are seen on anterior segment, signs of inflammation, and on ultrasound also we have the characteristic membrane and clump echoes which help to differentiate between the two, and it can also be confirmed with a blood culture, AC and vitreous tap. ROP stage 5, which presents with retrolental fibroplasia, is also a mimicker for retinoblastoma, but there we have the closed funnel retinal detachment, which are seen with associated retinal loops. So the ultrasound features for leukocoria, which are closed differentials for retinoblastoma. First is retinopathy of prematurity. The axial length is typically short and it can be bilateral, and total retinal detachment with retinal loops are present. In PHPV, there is a vitreous band from the lens to the optic nerve. The axial length is also short and it is unilateral mostly. Coats disease, we have the exudative retinal detachment with subretinal echoes, and the axial length is normal and it is mostly unilateral. In toxocariasis, there can be a peripheral granuloma, retinal folds and posterior traction retinal detachment. The axial length is normal and it is mostly unilateral. Endophthalmitis, we have the characteristic membrane and clump echoes. Axial length is normal. It is also, it can be unilateral or bilateral as an endogenous endof. Cystosarcosis, they have on ultrasound the characteristic cyst with the scolex, and axial length is normal. It will mostly be unilateral. And the rare tumor, medulloepithelioma, also called the dictyoma, will have a ciliary body mass with cystic cavities on ultrasound. And clinically, we can see deficient zonules in the region where the mass is present.
Okay, just a point that cystosarcosis, the scolex is dense spot not because of calcification. Scolex is dense basically. Okay, if it will get calcified only if it is dead, not in a live worm. Okay.
I think a lot of reasons why we miss retinoblastoma is because we assume the axial length is normal. So many slides you have shown saying it can present as ophthalmos, it can present as phthisis, but your ultrasound says axial length is normal. I think that's the first thing we need to understand, that retinoblastoma can present in a phthysical eye, can present in a ophthalmic eye. So that statement is absolutely wrong.
Yes.
Okay.
So actually the point would be that in general, a microphthalmic eye is unlikely to be harboring a retinoblastoma. That's what is suspected, that's what is told, but that is not a gospel truth, okay?
Yes, sir. As ma'am told, there is also a case of ophthalmos here where the presentation, it showed the features of hyper intense lesion present with calcification and back shadowing, and we can notice the difference in the axial length between both the eyes. In the left eye there is 29.47 mm and in the right eye it is 23.57 mm. So this was a case of retinoblastoma presenting with ophthalmos, and it can also present in a child with hyphema with a history of trauma. This is also our in-house case, so it can be, the history can be misleading. Here we see a homogeneous mass with calcification again with back shadowing. The MRI features of RB in T1 lesion, there is an enhancement, hyperintensity. This is the retinoblastoma. And in T2 lesions, we see hypointensity, and within that, more hypointense is the calcification. And again, this is a T1 image where you see a mild hyperintensity, and in T2 we can see the hypointensity. The most common mimicker, which is Coats disease, in CT we see homogeneous hyperdensity, which is seen, and in T2 images we can see the retinal detachment, which is seen here. And this is a contrast enhanced T1 image where you can see a diffuse increase in the intensity of the signal. So Coats disease can also have rarely calcification, in which cases we may even have to do an MRI to confirm the diagnosis.
I think at the end of the day, the radiologist is not going to give you diagnosis. They'll say correlate with your clinical presentation because they cannot be 100% sure. They can say there is a visible mass lesion. Barring that, they cannot say it is retinoblastoma or Coats disease. So let us not depend upon radiologists to give us a diagnosis. So we have to put all the pieces of jigsaw puzzle together and then make a diagnosis. And sometimes more than one examination is required to be able to diagnose. Okay, what if I am not able to make a diagnosis clinically? What other options do I have? The same child, for example, whom we saw, there are 50-50 division between the consultants saying this is Coats, this is pars planitis, then this is retinoblastoma. What else do we have that we can do?
We can give a trial of steroids.
Trial of steroids, he's already on steroids. Drops, nothing has happened. Do you think we can do AC tap?
Yes.
So that's one option. But trial of chemotherapy is not the same as trial of steroid. Chemotherapy is potentially toxic drug. So when you give that, your diagnosis is more towards retinoblastoma and less towards pars planitis. Only then you can suggest a trial, okay? But otherwise, you'll have to be unfortunately invasive. If you are clinically more in favor of inflammation rather than retinoblastoma, but that lurking fear is there, then you do AC tap, okay? Yes. All right.
So the international grouping of intraocular RB, we are the lesions which are typically less than 3 millimeters are grouped as Group A. Group B is that which is greater than 3 millimeters, and those which are less than 3 mm from the fovea or less than 1.5 mm from the disc. And Group B tumors are those which are less than 3 mm having subretinal fluid. Group C are those which are having focal, subretinal or vitreous seeds. Group D is that which are having diffuse vitreous or subretinal seeds. And Group E, as in our case, it might be seen in those patients with neovascular glaucoma, those with anterior hypopyon, and those which are having scleral invasion or orbital RBs, which would require an enucleation. We also have the International Retinoblastoma Staging System. The TNM staging, AJCC with 8, which gives more importance to the RB1 mutation, where HX is the unknown or insufficient evidence of constitutional RB1 gene mutation. H0 is normal RB1 alleles after testing in blood, which demonstrated high sensitivity assays. H1 is for patients who have bilateral RB or those having an RB with intracranial CNS midline embryonic tumor, that is a trilateral RB seen in pineoblastoma, and family history of RB, or those with a molecular definition or constitutional RB1 gene mutation. So this is the armamentarium of
I think we will probably not discuss the management part. All right.
So the take home is that in a child presenting with hypopyon or leukocoria, the final diagnosis is established based on detailed history taking, clinical examination and appropriate investigations. We should always keep malignancy as a differential in a child with a white eye hypopyon and in eyes with camouflaging signs like thysis bulbi or buphtalmos with intraocular calcification on ultrasound.
Have you gone through any retinoblastoma articles that tells you anti-segment findings can be there without an obvious tumor in the back of the eye? Have you seen any article? There is one by Vikas Ketan and myself of an eyeball where we ultimately enucleated that eye, and Krishna Kumar had to spend hours to look for the tumor in the retina, but anti-segment was full of tumor cells. So there was no retinal tumor visible. It's probably arising from the pars plana epithelium. Okay? So you can have such a finding, like in this case is almost arising so anteriorly that posteriorly there is no tumor. Okay?
Yes, sir.
Yeah.
So there is something, an entity known as diffuse anterior retinoblastoma, where you may not have an obvious mass arising from the retina at all. What you see in the anterior chamber are the seeds, which, as you mentioned, can be either depository or infiltrative. But these are actual tumor seeds, and there may be a lesion involving the ciliary body. Another important differential diagnosis in this case is medulloepithelioma, because medulloepithelioma can also present with anterior chamber seeds and very similar MRI characteristics. So it's actually very difficult to differentiate when you don't have a clear mass in the retina itself.
So in middle epithelium, very often you find cystic spaces within the tumor. But in this case, you don't find cystic space, and you can get sometimes a fibrovascular membrane-like thing behind the eye. Okay.
Or a zonular deficiency, an area. Yeah.
So in the examination, if you are asked what investigations would you do, would you say AC tap? You will 100% fail the exam. Okay. Please don't tell the AC tap. Okay. So that is the last thing which we are discussing here, because that is sometimes you are faced with that kind of a dilemma. But never mention AC tap as investigation for retinoblastoma. Okay.
So biopsy is never a choice for retinoblastoma. If at all you have to do in such a case, then it should be a clear corneal one, where you take an AC tap, and even in those cases you may not really find anything on cytology. Now what is coming up is a concept of cell-free DNA on liquid biopsy, which can help to diagnose such cases where it's difficult to diagnose it clinically.
Because those are cases where the antechamber is actually not having any tumor or hypopyon, but in the back of the eye there is a tumor, but you get the DNA in the antechamber. So their AC tap is pretty safe because there is no tumor in the antechamber, unlike this case. Okay. In fact, there's one case which I did with JB long back, where we had a doubt about the diagnosis, and we decided to do vitreous tap, bar enucleation same time. So we actually went through the cornea, through the zonules, through the iris root, into the vitreous, and took the tumor. And because there are multiple interfaces, it gets washed off, doesn't get carried over. So we went through the clear cornea, but through the iris root. And it showed malignancy, so we enucleated at the same time.
It is the adult retinoblastoma.
Yeah. Any other questions? I think we have already spilled over beyond 1 hour of the time limit for mental shutdown. So anything else? Any other questions?
I would just like to add one point. In a diffuse infiltrating retinoblastoma, you may not see calcification. So in that situation, ultrasound also will not pick it up. Neither will the MRI pick it up. So your CT also. So, and diffuse infiltrating is not known to occur in younger age children. They are little older. So this particular category, like 4 years and beyond, you can have diffuse infiltrating. That's one thing. And MRI will also help you in terms of picking up a choroidal invasion. That is another, because when you have calcification, your ultrasound may not show anything and you will not be able to see beyond that. So if your MRI is going to show an enhancement of the choroid, you will be able to pick up how much it is, because that will in turn tell you that if choroidal invasion is more, so chances of Mets are very high. So whether you would like to salvage the globe or not to salvage, you can probably take a decision based on that.
And diffuse infiltrative retinoblastoma or eyes, sometimes people have undergone surgery thinking it is some other RD, rather than a diffuse infiltrative RB causing the retinal detachment. So these are all mistaken diagnosis because of the reasons she mentioned: no calcification, the odd age at which it occurs, etc., etc. Thank you.